So let's talk about navigating countertransference questions and how can we find the best answers to these questions. And also we can apply this to how we work with our own clients, in therapy. One of the things that I've always noticed when it comes to the countertransference questions, as well as transference questions, with the transference that we have with our clients as well, I'll touch a little bit on that as well. But one of the things that I've noticed about any of these questions is there's maybe 3 responses that you can look at in order to be, trying to find the best answer for these questions. It's going to be either refer out, seek consultation, supervision, or you can have therapy on your own when you see with a client. But haven't really seen a lot of responses with questions that tells you to, seek your own therapy, and we will navigate that together. So here it is. Some of the key terms are transference and countertransference. Now, transference is what? That is the client. The client is projecting those feelings about someone else onto you, right? Onto the therapist, right? Maybe you remind them of their mother. Maybe you remind them of their father or a little brother or a little sister. I've experienced this with some of my younger clients, especially my teenagers. My teenagers will tell me, well, you remind me so much of my mother, that's why I treat you that way. And I'm like, excuse me? So yeah, it has happened to me quite a lot. Countertransference, when the therapist projects their own unresolved feelings, experiences onto their clients. And again, I've experienced this as well too. Sometimes if I do get a referral and I see that the reason why they are coming to therapy is because they've recently lost their mother, or they're still trying to get over some of the childhood trauma they experienced due to an abusive father or something like that, I will look at that referral and be like, can I help this client? Can I really, work through this client? Because some of the times I do feel like I have some of that unresolved trauma that I have. And it is hard for me to navigate a session when I have a client that is crying, talking about their mother, and their mother reminds me so much of my own mom. And I be feeling like I want to cry at that moment. And that's when I'm just like, Carrie, keep it together. What are you going to do? You just got to get through this session. So I've experienced it as well. I know that many of us probably have. And if you have, I do urge you to seek consultation. I do urge you to talk to someone about it so that you are not harming your client with the countertransference that you are having. Countertransference and transference is more relevant to the psychodynamic theory, but you will see it across all different other theories where it's not just tailored to just the psychodynamic theories. So what does the exam want when it comes to these questions, right? That's ethical. Ethically, if you have some countertransference going on, you should not continue working with that client. After you seek supervision and you still feel like you're having some of that countertransference, you should not be working with that client. Ethically, you can't. The self of the therapist reflection. Realize when you need to seek consultation. I need to realize when I need more support. I need to realize that right now I need supervision, right? Also, when you are experiencing some countertransference in therapy and it just so happens that it happened in that session, you need to have an appropriate clinical response. Again, that's the self of the therapist, realizing, hey, Carrie, hey, you're having a strong response right now. How can you clinically respond without harming this client, right? And 9 times out of 10, you're going to look for the answers that involve the self of a therapist awareness, supervision or consultation, or you need to be referring that client out if the countertransference is strong or you are harming the client, right? Here it is. These are some clues, and you don't have to look at the screen. It's just there again for me to remember what it is I need to go over. When a question involves transference, that is the behavior response from that client that may seem just a bit extreme, just like I said about some of my teenage clients, where they would tell me, I would ask them well, why are you yelling at me right now? I'm not yelling at you. And then they'll tell me, because what you just told me, my mom tells me that, and I hate it when she tells me that. So they start to treat me, they start to project, how they feel about their mom onto me. That's the transference from that client, right? And some of those best answers involve you doing what? Exploring the past experiences that they've had. But you cannot become reactive to it, because if I was to become reactive to some of my teenage clients and everything, I would probably be like, I know your mother tells you to do this. I know your mother yells at you, and that's how I would treat them. I cannot be reactive to that, right? I have to be more therapeutic with them versus being their mother, right? So when a question involves countertransference, that is us. We have these emotions that are just like, I can't believe you did that after I told you not to do that. Now I'm being judgmental and being biased. I'm being disengaged, like sitting there like, oh my God, here she is again, still messing with this same man that I told her to leave him alone. I'm not paying attention to what they say in therapy. I'm probably thinking about what I'm making for dinner when I get home, right? Unusual emotional reactions to our clients, like, oh God, I can't believe you hit your wife last night. You are just the scum of the earth. I can't work with you, right? But some of the best answers are going to include what? We need to be seeking supervision, increasing our self-awareness, know when it is time to seek consultation or refer that client out, right? Also, boundaries. If you're finding yourself like this client is constantly contacting you, I need to speak to you, I need to call you right now, constantly texting you, know your boundaries, because now you're probably doing what? You're too involved. You're overly involved, right? Know when to refer the client out in serious cases, and we will talk about that, how to recognize some of the serious cases when it comes to the exam and when you need to refer out. Eliminate. This is a strategy that goes for any domain, any question. Eliminate. You want to avoid questions that involves you confronting the client directly, right? Build rapport, like make it clinically. We're not confronting our clients directly about transference, right? We don't want to make them feel some type of way. They probably don't even realize that they're doing it. It is our jobs to at least be like, let's explore that versus confronting them about it, right? Lack of therapist insight. Again, that's you, right? I know I'm feeling some type of way, but it's okay. I'll get over it. I'll look past it. I can still work with this client. No, you can't do that. If you have the countertransference and it's there, you need to be working on how you are going to work through that, right? Suggest acting on countertransference instead of managing it. You cannot do that. I know there's psychodynamic, and that's what that theory is like really big on, the countertransference and transference and things of that nature, where you allow it, you accept it, but then you have to separate from it. But sometimes you need to know when you need to manage the countertransference effectively, right? So the red flags are back. Here it is again. These red flags in this vignette that we just cannot ignore. Red flags for strong countertransference will be what? Look for words that is emotional reactive. Now I'm having an emotional reactive to this client. Like I said, you went home and you slapped your wife. Are you kidding me right now? Are you serious right now? Because I'm a woman and now I feel like he's a woman beater and he shouldn't be doing that. Loss of objectivity. Like, oh, okay, well, here it is. It's there or whatever, but I don't know what it is that I need to be doing right now, so I'm just going to say this or whatever. And then it turns into where it's like now you're not remaining neutral, right? You may be picking a side, you may be taking a side with this one or siding with that one. Boundary issues. Again, like I said, there are boundaries with your clients. Your clients should not just be calling you, texting you any old times of the day, and you're responding to it. You're over involved in your clients' lives. You can't do that. Boundary issues also comes into the lines of like, oh, now I'm having feelings for my client, and now I may want to ask them out to the movies. No, you can't do that. Client safety risk. Know when your countertransference is too strong, when your client becomes at risk, when you're sitting there disassociating in therapy, you're not paying attention to them. They probably just told you that they want to kill themselves, but because you're disassociated and you're disengaged, now you're not even listening. It becomes a risk to the client, right? These are some of the common phrases, and I took these, of course. I've been looking at them, trying to find out, like, how can I find the best way to put it? And I've looked in AATBS, Jerry Grossman. These are some of the common phrases that you will see, that suggest strong countertransference. The therapist feels unusually angry, protective, or attractive to that client. Just like I said, he pissed off and mad, he hit his wife, yada yada yada. Oh, now I need to be more like, I need to protect this family. It's like, okay, well, that's not your job to protect them, only in certain circumstances, right? But now if it becomes overly that you're doing that and you're constantly calling, hey, are you okay? Are you okay? How you doing? You can't do that, right? Attracted to the client. Just like I said, you shouldn't be taking none of your clients out to the movies. You can't do that. Or ask them for breakfast or a lunch date. Can't do it. The therapist is reminded of someone from their past, ex-partner, parent, or child. Like I said, like some of the times I get clients and I'm just like, oh my God, you remind me so much of my father. And then it's like the relationship I have with my father starts to like impede that. So now I'm like, oh, I can't stand you. Well, I guess I can work with you. If no, I can't stand you, then yes, we have some issues that's going there. Preoccupied with the client outside of session. Again, boundaries. Calling, texting, constant talking, over involved, can't do it. The therapist fantasizes about a relationship. There's that lunch date again that you're trying to take your client to, can't do it. Nope, don't do it. The therapist loses neutrality and becomes over involved. Just like I said, you lose an objectivity. Now it's like you can't become neutral anymore. You're taking sides. You're feeling like, oh well, this person is right, this person is wrong, or whatever because of what this person said or what this person may have done. You can't do it. The therapist avoids discussing certain topics. Again, like I said, when it comes to a client of mine that I know that has recently lost their mom, I can't, I don't want to talk about that because then it makes me feel some type of way. The red flags are flagging. Once you see them, you cannot ignore them. When it is time to refer out, the therapist countertransference impairs your clinical judgment. So now your countertransference is overriding clinically how you are going to work with this client. Now you're probably sitting there trying to be that client's friend because she going through the same situation that you went through with, I don't know, Billy Joe and Bob or whatever. So now y'all just sitting in there having a pity party or a girls' night with each other in session. Can't do it. It's time to refer out if you have not already sought consultation for it, right? The therapist cannot remain objective. Just like I said, working with a couple, you hit your wife last night. Now you're probably about to be angry and pissed off because he a wife beater and you don't want anything to do with them because you probably was in a relationship where that happened to you. Supervisor consultation has not resolved the issue. You must refer out. If you get a vignette that says seeks supervision and it's still not working, your best response better be to refer that client out, right? Therapist experiencing strong unresolved personal reaction, unresolved trauma that is triggering to that therapist. I use myself as an example because I know I have had a client where it was like so triggering listening to her stories about physical abuse as well as stories about her mom and everything, and I'm just like, I don't know how much longer I can do this anymore because now she's crying in therapy and I feel like I should be crying right now and I feel like I should be in therapy, so I had to refer out. That's it. That's all, right? So the correct answers might include something like this: seeking supervision or consultation. Refer the client to another qualified professional. If it is strongly presented that therapist is having strong countertransference, then you're going to refer out, or just like it's always ethically, you cannot continue to work with a client where you experience countertransference because there may be harm that you may be doing with the client. Assess the ability to provide objective treatment to this client. You cannot let biases. This is not about you. This is about the client. And when that is clouded by your judgment, then it's definitely is time for you to think about seeking consultation or referring the client out. Here are some exam tips, and this is how I learned to answer these kind of questions the correct way. If the countertransference is moderate, then you're going to look for supervision or self-reflection, right? If it's not strong, don't be so quick to refer out, and you will know if the countertransference is strong by the way that the vignette is being presented to you. If it is strong and ongoing, then the best answer is obviously going to be for you to refer out, and you will be able to tell, judging by the different, I'm going to show you how to look at the questions both differently, right? Pay much attention to how that countertransference affects the therapist's objectivity to the client's welfare. That is like how if a therapist is saying every time before a session starts with this client or before it starts with this family, they get very, very anxious, heartbeat, like almost panic attacks, I think it's time for you to refer out, right? So you want to choose supervision if there is still a way for you to help with your clinical recovery of helping with this client. Seek consultation. Just like I did, I had to seek consultation. I did, and then I retried it again, and it still didn't work. Because now, at any given moment when my client started talking about her mom, I'm not even listening to what she's saying because I'm thinking about my own mother. So now what am I doing? I'm disengaged, I'm disassociated, I'm not even paying attention to her. So how can I help her, right? Choose referral if the therapist has lost neutrality or is compromising care. Again, like I said, about that scum of the earth, because that husband hit his wife. Now it's like you siding with the wife. Girl, he should have never did that in the first place. You should have never went back home. Nope, can't do it. Got to refer him out, right? Avoid answers that suggest you acting out your countertransference. Over disclosure or excessive accommodations, you can't do that. If you constantly keep finding yourself, I got to see consultation because I can't get past it, it's time to refer out. And you're not about to be disclosing to your clients, oh yeah, girl, my man used to do that to me too, and this is what I did. Nope, can't do it. Same way for you guys. I had a girlfriend that was like that one time, and this is what I did. Nope, can't do it. Time to refer out. You're not sitting there doing no over disclosure because now you think that that's clinically appropriate. No, it's not clinically appropriate. Refer them out. Let's go over some questions, and we're going to walk through them the same way we did for the practice of systemic therapy. So, a therapist has been working with a client who reminds them of their estranged adult daughter. Over time, the therapist begins feeling usually invested in the client's success. Frequently thinks about the client outside of sessions, finds themselves minimizing the client's problematic behavior, and the therapist has discussed this in supervision, but reports that they're still struggling with the objectivity, right? So now your whole clinical judgment has probably been impaired because your estranged daughter reminds you is something that they did in the past. So now you're just like, well, I don't think anything that you're doing is wrong. And you know why? Because your daughter done probably gone somewhere or whatever, and now you're just gonna project this onto this client, right? So if you were taking this exam and this question was on it, what would you highlight? Let's go through that, right? We can go ahead and highlight estranged adult daughter. We would highlight that. The therapist's feelings is what we would highlight, which is she being invested in her success, thinks about the client outside of the session, and is minimizing the problematic behaviors. So let's take a look at it. What is a therapist's best course of action, right? So remember, best course of action is steps that we are going to take in order to help with this issue. A says continue therapy while maintaining increased awareness of their emotional reactions. Well, okay, I'm glad that you are aware of your emotional reactions, but what are you going to do about it, right? B says, use a relationship as an opportunity to heal unresolved family issues through the therapeutic process. First of all, that client that you're working with is not responsible for your unresolved family issues. You need to have a therapist to do that with you, not your client, right? C says, refer the client to another therapist due to ongoing transference. Okay, sounds nice. But let's look at D. Set stricter session boundaries and avoid discussing. There it is again. There's that red flag, right? If we have to avoid it, discussing it in therapy or whatever, then we may not need to be working with this client because that means that we've got some countertransference going on, right? Refer the client to another therapist due to the ongoing countertransference. You've sought supervision already. You've already discussed in the supervision and it's not working. So that means what? It's time for you to refer out due to the ongoing transference that is happening. You don't want to cause any more harm because it's clear she has some unresolved family issues going on and she may need more support in that area before she can work with a client like that. Okay. A therapist is treating a client who has a history of domestic violence, similar to the therapist's own past experiences. Remember, I was talking about that, right? The therapist notices themselves becoming emotionally numb during session and has difficulty empathizing with the client's perspective. They haven't shared these reactions but continue therapy with the focus on behavior interventions. Before you look at the answer responses, go back and see. If you were taking this exam today and this question was on it, what would you highlight? What would you look at that's going to stick out to you, that's going to help you find your best answer? The first thing that I will highlight is domestic violence, a history of domestic violence, which is similar to the therapist's own experiences, right? Then you can also look at becoming emotionally numb during sessions and difficulty empathizing with the client's perspective. But then we can look down and say that what should the therapist do next? Remember, next questions is what you're going to do literally right after what is happening in this vignette. We're not going to be looking further down the line. What are we actually going to do next that is presented in this vignette? A says, refer the client out to protect the integrity of treatment. Okay, let's come back to that. B says, continue sessions as they are using structured behavioral tools. Well, I get that they're using the behavioral tools because it says that they're using behavior interventions, but it does not include what the therapist needs to do. If we look at the red flags, she's having some countertransference. So we just cannot continue sessions because we're using behavioral tools, right? That ignores the fact that the client is obviously going through something and the therapist experiencing some countertransference from it, right? C says seek supervision to process their emotional detachment. Okay, let's go back to that. D says disclose their own history to the client to build rapport. Remember what I said. If we have to start disclosing what we're doing in our own lives, it's a bit much. It's becoming a bit much, right? That leaves us with A and C are two of the responses that we have left, right? If we go back to the vignette, what we highlighted was they haven't shared these reactions, but they continued therapy. So the first thing that she needs to do next is going to be do what? Seek supervision to process their emotional detachment. It's not as severe, right? It's not severe yet, so we're not going to refer out yet because she hasn't sought consultation or supervision yet. So we are going to seek supervision to process their emotional detachment. Remember, we're not jumping the gun here, right? The vignette says she hasn't shared these reactions. So let's seek supervision and see how we can find support with that. A client in therapy is emotionally volatile and often praises the therapist as a lifesaver. The therapist begins looking forward to session as a source of validation, and starts extending sessions beyond, the allocated time. Well, this client is she's first on the list, right? Despite recognizing these feelings, the therapist believes that client dependency is part of the therapeutic process. Now your objectivity is just out the window, right? Our clients should not be dependent on us, right? What is the most clinically appropriate response? Confront the client. Remember what I said about those confront the client responses. Confront the client about the dependency and reinforce time boundaries. So now, after you've broken the boundaries, now you want to reinforce the boundaries. We're not confronting our clients, especially when this is something that has to do with a therapist error, so to speak. B says in therapy as the dynamic is no longer ethical. So not only are you going through countertransference, this client of yours think that you're this lifesaver and highly looks up to you. Now you're just going to abandon them. Unethical, we can't do that. C says reflect on the dynamic and supervision to assess for countertransference. Okay. Let's look at D. Reframe the client's behavior as a normal part of the attachment process. First of all, nothing is normal about you wanting to come to session to hear your client validate you. Nothing is normal about that. So we're automatically getting rid of D and taking a look at C. Reflect on the dynamic and supervision and assess for countertransference. It's not strong yet. It's not too severe yet, right? So we're just going to reflect on the supervision and assess for countertransference, right? A therapist begins treating a client involved in a high-conflict custody dispute. The client frequently criticizes their ex-spouse, triggering the therapist's memories of their own divorce that they went through. The therapist starts agreeing with the client's views about the ex-spouse and offer unsolicited advice based on personal experience. Remember what I talked about, right? Now you in there having a pity party with your girl and stuff. The therapist often feels that they are finally helping someone who gets it and dismisses the concerns brought up by the supervisor. So that tells me you've already sought consultation, supervision, whatever the case may be, but you're still sitting in there like dogging the ex-spouse because you done gone through whatever you done went through, right? So what is the most appropriate next step? So before we look at the answer responses, let's take a look at what we will highlight if we were actually taking this exam and this question was on it. So a therapist begins treating a client involved in a high custody dispute. I don't really think you need to highlight that, but you can highlight the client frequently criticizes the ex-wife or the ex-spouse, or whoever the case may be, triggering the therapist's memories of their own divorce. Definitely highlight that. And then definitely highlight that therapist is now agreeing with the client's views about the ex-spouse, right? And then also unsolicited advice based on personal experiences. Definitely highlight that, right? As well as what's written in quotations. Finally helping someone who gets it, because of what happened in your divorce. Now you want this other person to be like, oh, yeah, I see what you're talking about, girl. I agree. I get it. I went through the same thing, right? So A says, reframe the therapist's reactions as empathy and continue treatment with caution. First of all, how are we going to reframe the therapist's reactions? Is the therapist going to reframe the therapist's reactions? Is the therapist going to reframe their own reactions? I don't get it. B says, shift to a solution-focused model to maintain objectivity. So switching to a different model is going to help you not agree that her ex-husband or whoever the case may be is the same as your client's ex-husband or wife or whoever the case may be? Oh my God, no. D says apologize to the client for overstepping. That client is going to be like, what are you talking about right now? Because this client has somebody who is like, this is more like a lunch date where we just, shit talking about our exes or whatever. That client is going to be like, I don't understand, right? So C says refer the client out due to unresolved countertransference, impairing clinical judgment. This is a moment where you are going to refer this client out. You have gone too far, because now what are you doing? You're also giving advice on personal experiences. So that means that you're over disclosing, because you've lost objectivity about what's going on in therapy with this client, because you're experiencing your own too much strong countertransference. This girl has gone through it. All right. A therapist is working with a client who has recently been convicted of a violent crime. The therapist, a survivor of a violent assault, begins experiencing panic attack symptoms before sessions and struggles to remain present during treatment. Aww. Despite efforts to use grounding and clinical strategies, the therapist disassociates during sessions and experiences nightmares after meeting with this client. Oh my God. I've had countertransference strong, but I don't think I've had it as strong as that. Oh my goodness. What is the best next step? So before we look at the answer responses, always let's look and see what we can highlight that is going to help lead us to our best answers. Recently convicted of a violent crime. Therapist is a survivor of violent assault, experiencing panic attack symptoms, right? She's struggling to remain present in therapy. She's tried the clinical strategies and she disassociates. Those are some of the red flags that we just cannot ignore in the vignette that we need to highlight and pay attention to. So what is the best next step? Again, we know your next step is going to be exactly what you're going to do after. Nothing down the line. What are we going to do after, we've just discovered that we are going through these strong symptoms of countertransference. A says continue treatment while managing symptoms with mindfulness and self-care. She's already done the clinical strategies. She's already done the grounding techniques and it's not working. So we would automatically get A out. B says seek intensive personal therapy to resolve trauma while working with the client. We're going to talk about this response here, so let's come back to it. D says disclose the shared trauma to build client understanding. The client is already going through enough as it is, and then now you're going to disclose and put more on top of that, furthermore possibly harming the client. We can't do that, so that'd be unethically wrong, right? Mutual trust. I get it that it's like building rapport, but no, that's not the route that we want to take. Let's go back to B. Seek intensive personal therapy to resolve trauma while working with the client. I have seen questions. I have seen answer responses that include seeking personal therapy. I have also seen answer responses that tells you to seek therapy, and that is the correct answer. You will know when you see a vignette based on the scenario, based on what's going on in the scenario, when you can choose seeking personal therapy while you are working with this client. When you look at this vignette, you see that this countertransference is far too strong to seek therapy and still work with this client without at the same time hurting that client, right? The countertransference is far too strong to be waiting on you working on your own personal trauma responses to help with this client. So that leaves you with C. You need to refer the client out due to the inability to maintain emotional and psychological safety. So the client's welfare is always going to come first. And if you are struggling with maintaining your own emotional and psychological safety, what do you think that you are doing to that client? Keep that in mind when you are looking at the countertransference questions. I hope this video will help you take a different look, a different perspective when it comes to countertransference and also when it comes to transference. I can also do a video for transference as well, but I kind of figured I wanted to do countertransference because I know some of these questions people can get confused on when you should seek consultation and when you should be referring out. So again, drop a comment, leave me a message, let me know if you have any questions, comments, or concerns.